Welcome to EMDR Chat with Curt and Michelle. I'm Dr. Curtis Rounzen.
I'm Dr. Michelle Gottlieb. And Curt, can I just start with it's so much fun to actually see you while we do the podcast, and
Is
that we,
is it?
yeah, we get to do this visual thing now. It's pretty cool. I like it.
Yeah.
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 Okay. But Curt, I gotta tell you, I don't know, I know you know this, but we also have like a TikTok account and we put things out there all the time on TikTok and Instagram and all
You
kinds of
know,
stuff.
I used to use Tic Tacs all the time.
I
You know.
again, Curt,
Uh,
no, but nice try.
oh,
But what's lovely about it is people keep asking us questions, which I think is fantastic. And a question
ah,
that's been asked is EMDR therapy basic standard protocol? Is that enough for my tough clients? What's your thought about that?
wow. Um, I'm going to use a phrase I hear from you all the time, Michelle.
I know this phrase. Go ahead.
It depends.
Right? Mm-hmm. Mm-hmm.
You know, standard protocol is the basis on which all adaptations come from.
Right?
And there are times where the standard protocol may need to be adapted, like we teach in our trainings, based upon symptom clusters, based upon population, for instance, addictions versus psychosis, depression, grief. All of those may have some adaptations, but the basis on which all of those adaptations are centered around is the standard protocol.
And good point, because I know often, because I'm pretty strict on standard protocol, I follow what research has taught us.
Right,
And I find that often simply doing standard protocol, including cognitive interweaves,
right.
even for my toughest clients, can move them through. Now, it may move them through slowly, but maybe that's part of what people are getting concerned about is it's not going fast enough.
Well, it's interesting because with, before EMDR, it didn't go at all.
Right?
And so now it's going, and they're expecting this, like miracle cure, that you see. And the reality is how fast EMDR goes is based on the complexity of the presentation of the client. Complex PTSD, developmental trauma, doesn't just have one or two major traumatic events like a war experience or a major crime, but it has hundreds of small T traumas mixed in with large T traumas. And so the very fact that it impacts the developmental phases of that child, the brain development itself, trauma does, well, it's going to take longer. And I just want to remind everyone out there about the ACE study, Adverse Childhood Experiences, and their conclusion of with over 17,000
Mm,
patients
hmm.
that the primary cause of death, disability, and disease is adverse childhood experiences under the first 18 years of life.
Right.
So the earlier the trauma starts, the more complex its presentation and the longer it's going to take. But I do think it's kind of interesting that people say, well, it's moving so slow.
Right.
Yes, but before EMDR, it didn't move.
Well, I'll give you an example of a question I got asked this morning. I've done 8 sets. They're not done yet. Yeah, like
Uh-huh.
that's hardly nothing, right?
That's right.
So, but
That's
okay.
right.
So for everyone watching and listening, when would you say maybe we need to bring in some of the adaptations? What would be the signs that just standard protocol isn't working, that maybe we actually do need to do something else?
Well, I think one of the ones that jumps out to me immediately is addictions.
Hmm.
With addictions, one of the things we also may do is do detour, which is targeting the cravings themselves.
Hmm.
And so you do the early traumas that led to the addiction in the first place because they're trying to alter a state of consciousness, which was bad, and that's why substances are used. But there's also the cravings, and targeting the cravings. I did that just this week with one of my patients who is trying to get off a chronic years long use of marijuana because it's impacting his thinking ability, his working ability, his motivation, all the stuff that is out there for the chronic long term use. And the cravings had just been driving him nuts. And so we were going after the the cravings, and he had a significant reduction in his use from the last session.
Right. I love that. And I'll give you an example that I often think about is for our complex folks who their window of tolerance is like that big, itty bitty. They
Yeah.
have no skill sets. And so bringing in DBT, dialectical behavioral
Oh,
therapy,
yes. Yes.
right?
Yeah. And even CBT as part of
Mm-hmm.
coping skills,
Mm-hmm.
that sort of thing, is very useful. I mean, we even talk about that in our trainings because DBT is an excellent, I view it as a way of coping, a way of teaching our clients the skills to deal with dysregulations that they never learned because
Mm-hmm.
they had a caregiver that wasn't able to or did not soothe them, maybe by choice or by circumstance, and they didn't haven't learned the ability
Right.
to soothe because the neurology wasn't innervated the way it should have been for a normal little baby.
Right. Right. So for our complex folks, we might need to do an extended phase 2 preparation where they're doing more resourcing. We
Yeah.
might not as well. Don't assume you're going to have to, right? But you might need it. So that might be a use that you would bring it in. Um, something you hear about a lot now is the flash technique.
Yeah.
And again, I think this is another great one for how my understanding of the flash technique is during phase 2 preparation, where if someone out of their window tolerance, 0 to 10, how disturbing that is this? It's a 15, but we can use flash to get them back within their window of tolerance so that we can actually do reprocessing with them.
Absolutely. And what I really appreciate about Phil Manfield, who developed the flash technique, is that he's done research on it. You
Mm-hmm.
know, this just isn't a feel-good kind of thing. Phil has done research on it, and the flash technique can be very useful for those types of patients that are, again, overwhelmed. And it's been very useful. And many of our EMDR clinicians have found it extremely useful as part of the preparation phase.
And another thing that a lot of people are starting to use now, not just now, it's been around for a while, is polyvagal.
Yes.
Now, how would you use that? I mean, theoretically, I think it's fascinating, but how would you actually use it during reprocessing, during
Well,
EMDR?
let me put it this way. I think we automatically do it
Mm-hmm.
when we're doing EMDR because one of the things that I find as I've looked at all these different approaches to treating the trauma, those that have a lot of research and those that have minimal amount of research, regardless of how much research or no research, regardless, one of the things they all have in common is a downregulation or a calming of the nervous system.
Mm-hmm.
And so you're dealing with a polyvagal response when you're calming the nervous system. And so I think one of the common things that brings the thread through all of these approaches. Now, I certainly think EMDR has the most research, and we have shown literal brain scans, PET scans, SPECT scans, the changes in the brain pre and post treatment. That's also reflected in the quieting down of the polyvagal response. So I think many of these, in a way, inadvertently have done this for years. The polyvagal is just a wonderful way to focus on it specifically, a way of dealing with the dorsolateral vagal complex and that shift to
Mm-hmm.
ventral. But I think in many ways we do that. It's just more of an active focus on that part,
Mm-hmm.
I believe.
Which I think, and again, I don't know a lot about this, and I don't know how much you know about it, but DBR, deep
Oh
brain
yeah,
reorienting. And I
yeah,
think in some ways that's the same kind of thing that if something comes up physically, that we can say go with that. Where deep brain reorienting, DBR, will have a different uh, technique of dealing with it. But again, I don't know that
yeah.
there's research behind DBR yet. Yet.
Oh, Corrigan is from Scotland. He's doing some research on it, and again, he's working with Ruth Lanius, and
Good.
they're doing showing brain scans. Part of what is involved is in particular in dissociation. They've found a part deep inside the brain that is affected when with severe dissociation. And part of what they're doing with deep brain reorienting is trying to access that part of the brain. So it's fascinating, and I think there is a very good chance that we may be including that in our toolboxes
Hmm.
down the road.
Yeah. And that, okay. This is something you've heard Kurt and I say a million times. There's a lot of really cool stuff out there. Is there research? Right?
Right.
That's the bottom line. If there's no research, please don't do it. Like, we don't really know what it does. And there's a lot of things. Well, a great example of art and brain spotting. They're getting more research. So now
Yes.
I'm like more willing to talk about it now.
Yeah.
Um, but I
I
would
mean, I
say,
mean,
yeah, go ahead.
David Grand, who started Brain Spotting, he was an EMDR therapist,
Hmm.
back in the early days, and what do you call it? Natural flow EMDR turned into Brain Spotting, and it's been around since 2003. And I've always told David, I said, you may have something really great here, but do the research.
Hmm.
And they've done some comparative studies. Uh, there's theoretical kinds of thoughts about how it might work. But, if you Google it or if you look up the research on it, the evidence is very slim. That doesn't mean it may not be helpful.
Hmm.
I don't want us as old line EMDR people to do to other methodologies what was done to us.
Right?
It was poo-pooed and it was, said, oh, that's silly, and people just disqualified it. And so I want to be open to other possibilities that may be helpful, like art. I mean, accelerated resolution therapy, they've done some randomized control studies on it.
Hmm.
And so I look at it as, in some ways, they do imagery scripting, they do more visualization, guided imagery, things like that. But to me, it's kind of reminded me of what EMD was
Hmm.
at the very beginning. But I got to hand it to them. They started very, very slowly, like EMDR did in the beginning, very slowly, doing some comparative studies, doing some real randomized control trials. I don't think brain spotting has done that yet. I think there's been some comparative studies done, but that's where we need to go. All of these things may be helpful, but Francine was the one in the very beginning because of how EMDR was attacked and how she was personally attacked in the very beginning. Research, research, research. And it's her push that has allowed EMDR therapy to become one of the most tested and empirically validated treatment with randomized controlled studies. I think now there's over 40
Yeah.
since she started it.
So, okay, if you need something, do something that is research, that's evidence-based, right? That's good. But let's go back to the
Exactly.
original question. How do I know if I need to do something other than standard protocol? What are some of the signs that our folks can be aware of they might need to pull something else in?
Well, again, it depends.
Hmm.
I find but I've been doing EMDR for 35 years, right?
Great.
I find that, I really don't have to do much more than the standard protocol. I
Hmm.
just have to be sensitive to the client. If they're out of their window of tolerance, we have ways of bringing them back into the window of tolerance without necessarily having to ground them or pendulate them as some other approaches do. We may have to do the preparation and resourcing. But see, for me, that's still standard protocol.
You know what? This is what I'm really hearing you say, Kurt, that what you're talking about is attunement and going from the manualized treatment to the art of psychotherapy. And I
Right.
think that takes trust in us as clinicians, and it takes experience, and it takes failing, and it takes picking ourselves up and learning more. But it's the trusting ourselves, our whether you want to call it therapeutic intuition or whatever you want to call it. But what's interesting, years ago when I first started teaching at the university, I was demonstrating something to a group of students, and they said, Dr. Gottlieb, why did you choose to do this rather than that? And my first response was therapeutic intuition. And they said, we don't have therapeutic intuition yet. And I went, oh, good point. So to really, for us who've been doing it forever, to break down what therapeutic intuition is, what is that attunement? What is that art of psychotherapy that we're doing, that we can break it down to why we did this, and we didn't need to go on to whatever the new bells and whistles were, but it actually worked.
Right. It's the more experience you have. It's like the old psychology things of background and foreground. You
Mm.
know, the background is experience, and the more you have of it, that when you run upon something in a patient that others may see as, oh, I don't know, it's stuck. I don't know what to do. We have a large number of tool experiences that we can pull out and keep moving and allowing the client to process. I think a lot of it too goes back to therapist anxiety.
Yeah.
You know,
Hmm.
when a because as we say in our trainings, mental health professionals are one of the hardest groups to teach because they've been trained in graduate school that to fake competency
Hmm.
and fake it till you make it. And as a result, when they feel lost, when they don't know what to do in the beginning, if they get their anxiety goes up rather than trusting the process of EMDR, trusting the brain. I think when our participants get to that place, when they've stood back, stayed out of the way, haven't got their own anxiety up, and just let that patient's brain do its job as it was designed to do. And
Right.
they see it over and over again. And then they get back and they see these tough places and they go, oh, it's going to be interesting to see how this patient's brain deals with this.
Right. Right. So I want to add one piece to that.
Yeah,
Um, Perhaps what is missing, besides experience and trusting in themselves and the process, maybe what they need is a hand to hold. Maybe what they need is consultation. So when you get stuck, and by the way, I am not saying don't learn more, don't take more advanced trainings. I think that's important as part of our growth as
absolutely.
clinicians. But rather than just grabbing whatever, maybe what you need to do is find a good consultant. Let me emphasize, good consultant, because there's not so good ones out there, who have the experience and say to them, what do I do when this happens? I think that's a real important piece of it too.
You know, what you're really talking about, Michelle, is what I call clinical humility.
Uh-huh.
So much of what happens to us in the mental health field is that we feel we have to have all the answers.
Mm.
And if we reach out to a colleague and ask a question or try to collaborate, then it's viewed as weakness or I'm not as knowledgeable as I should be. No, it's that you're not as humble as you should be.
Hmm.
Uh, and when you're working with complex PTSD, trust me, clinical humility is very essential because, you know, if we don't have that, then we may not help the patients we're there to help.
And what I always say is, one of the reasons I love EMDR therapy is because I don't have to know all the answers. I trust their brain, right? I may have the structure for them, but I follow their brain, and makes it so much easier.
The other piece that is flashed on as you said that is that
Mm.
so many of the things that I've learned to do over the years is because I listen to my patients.
Right?
Was not in a textbook.
Hmm.
It was not in a workshop. It's the patient gave me feedback
Hmm.
that I then applied to another patient, and it worked.
Hmm.
And so it's listening to your patients and them guiding you because it's their brain
Right?
to what works, and then
Hmm.
seeing if it generalizes to another patient. So that's part of people say, well, how do you know to do that? Like you said. So, well, I listen to my patient.
Right? So, bottom line, people. You've got complex clients because we all do. That is our reality. And it's only going to get more complex. This world, unfortunately, every day there's a new trauma out there.
Yeah.
EMDR basic standard protocol works. Trust yourself. Yeah, sure, take more courses, take advanced trainings that have research behind them. Trust yourself. Get a good consultant. Trust yourself. Listen to your clients. Trust yourself.
Yeah.
And trust your clients' brains.
Well said.
Thank you, everybody. I'm so glad you were hanging out with us
Yeah.
today.
Till next time,
Bye.
go with that.